Sounds good. I think we'll kick it off and get started. So welcome, everybody. I'm Cynthia LaBella, and I'm current chair of the Practice and Policy Committee for AMSSM. So welcome to our annual webinar. We do this once a year in January. At least for the last 2 years, I've been chair of this committee. And our goal is to continue to do this once a year, mainly for two reasons: to update the membership who are interested in practice and policy, what our committee's been up to on behalf of AMSSM, as well as getting input and feedback and ideas from members on priorities and their thoughts on some of the initiatives we have going and some of the policy that's already out there. So, Brian, if you could go to the next slide. So this is an outline of the webinar tonight. Again, we're going to try to get through some of the updates each of our subcommittee leaders will be giving fairly quickly to give a broad overview so that we have plenty of time at the end for discussion and Q&A. The main goal, again, of this webinar is to get input from our members. And if you can't stay on for the whole webinar, thankfully it is being recorded, so you will be able to access the recording as early as, I think, Friday this week. Okay, next slide. So just to review who our leaders are in our committee. So we have 4 subcommittees under the Practice and Policy heading. The Legislative Subcommittee is headed by Sam Dixit, who's also the Vice Chair of our Practice and Policy Committee. Community Advocacy Subcommittee is led by Alex Diamond. Michael Schwartzen leads the Practice and Economics Subcommittee, and Luis Rodriguez leads the Healthcare Quality Subcommittee. We have a fellow liaison this year, Elisa Justo, who is also joining us tonight. And I think our fellow liaisons really play an important role linking the fellows to some of our activities. And so I really encourage any fellows who are listening in. I mean, you can always reach out to us as leaders, but I think reaching out to Elisa would be also a great idea. And then last but not least is, and Brian quickly went to the next slide, but I want to mention Brian Williams is staff at AMSSM and our Director of Policy and Advocacy, and has been a huge addition to our team. Joined about 2.5, almost 3 years ago now, right before the pandemic hit, I think, and has just been doing so much heavy lifting for this committee. So can't thank him enough, but he's going to also join some of the presenters tonight and help to update you all on what we've been doing. Okay, next slide. So where can members get updates? Well, we meet once a week, our leadership team that you just saw, and we post a summary of this on the AMSSM Collaborate website. So once a month, Brian takes great minutes of our meetings, and you can find that again on the Collaborate website. We also have an Advocacy Corner e-blast that goes out once a month that you can kind of see all the updates there. Next slide. So the mission of our committee, or I should say our committee, is tasked to advance the mission, AMSSM's mission, to advocate for policy that supports the practice, these 3 main areas: the practice of sports medicine, athlete health and safety, and also physical activity promotion. So those are our 3 main areas that we advocate for. Next slide. And then this is a real recent update. So just a couple months ago now, probably it was around November, early December, the board of directors, with input from our committee leadership, put together this policy on organizational stances. So this is kind of what guides us as an organization on how we respond to and take stances on some of the policy that gets, or some of the bills that are getting promoted through different state legislatures and at the federal level. We get a lot of questions about various bills across so many different topics. And so we really wanted to have some kind of core guide. So I wanted everybody to be aware of this. I'm not exactly sure. I think this should be posted on the members only portion of the website at some point, but right now This is the entirety of the policy, and I just highlighted in yellow kind of the key parts of it, which I'll kind of review. So as a 501c3 nonprofit organization, AMSSM is required to maintain a nonpartisan, mission-driven focus. And so this is kind of what guides us on this policy. And what we strive to do in the bottom statement here is promote policies that unify the membership. And therefore, we do not take positions on partisan, political, or social issues, or on topics that are not fundamentally related to sports medicine policy or issues related to the practice of sports medicine by sports medicine physicians. So, and then the last part of this is just referencing our 3-tiered sports medicine policy priority list, which again is posted and updated every year by our committee. So this is an opportunity to weigh in on these areas, these spheres that we regard as policy areas that are important to AMSSM. And again, what counts as important really comes from you guys, the members. So one of the goals of this webinar is to get input on these policy priorities. So if you can go to the next slide, Brian, this kind of breaks down these tiers that I mentioned. And I think sometimes the tier label is a little misleading. It does not imply that tier 1 is more important than tier 2, and tier 2 is more important than tier 3. The tiers just designate the different areas where, whether we take a lead role in the policy, whether we take an active role, but we're not necessarily the lead, because other organizations may have this as those topics as their main meat and potatoes of what they support. And then tier 3 are those that, again, are equally important to us as tier 1 and tier 2, but we're really playing a supporting role because there are so many other strong organizations that are advocating for these things as their primary mission. So we listed some examples here of what falls into the tier, each of these tiers. So things that are really essential or kind of make up what we do as sports medicine physicians that are unique to us, where our organization would really be the ones that should be taking the lead role on this. So examples are like the traveling team physician, pre-participation physicals and emergency action plans, concussion care, sudden cardiac arrest, AEDs or CPR training in schools and for athletic teams, opioids, athletic patient treatment concerns, player safety issues. Where we take an active role, our athletic training issues, again, NATA would take the lead role on things like that. And then a supporting role on topics like asthma, obesity, physical activity promotion. There are a number of other organizations that take lead roles on those, but we play an important role by supporting them. All right. So that's kind of a broad overview of how our committee is structured, what we do, what our focus is, and our priorities. So now we'll just go through each of the different subcommittees, and each leader will kind of take us through what their subcommittee's been working on, and then we'll save all the questions till the end. But I'm going to pass it off now to Sam Dixit and Brian Williams, who will talk about the legislative updates.
Good evening, everybody. This is Sam Dixit, and I'm lucky enough to work with this committee, and I thank Cynthia for her leadership and Brian Williams for all of his help to our committee in helping us put together this webinar, and also in leading the committee forward with all our efforts. You know, our primary sort of the legislative subcommittee is a little bit different than some of the other subcommittees, and a lot of our year-to-year work is the same, although obviously what we're advocating for can change from year to year. And as such, what we've developed over time with the effort of sort of really the years of leadership on this committee, as well as Brian's hard work over the last few years, are some resources that you can get through the AMSSM homepage. If you go under the advocacy web link, you find state legislative contact resources, and it's the handbook, and it's really an excellent handbook that sort of outlines some of the tier issues that Cynthia just mentioned, and then as well includes state legislative key contacts within AMSSM. So that's sort of a resource for members to advocate on a grassroots level. Obviously, as a committee, we don't have the bandwidth to take on all of these things, and we really rely on the grassroots advocacy of our members to help advocate for our state legislative issues. Our issue briefs are also included on hyperlinks through that page. They're in the handbook as well as in other locations on the web page. And then there's some government advocacy basics, and I think these are excellent. All of us have probably gotten away from when we were educated about all this when we were younger, and I think these resources are excellent and kind of go through how a bill becomes a law and things like that, and on how you can sort of work with the legislative lobbying or direct lobbying as well as grassroots advocacy. Next page. Next slide, Brian. And then kind of segueing to that, we have a advocacy map as well, which includes legislation by state broken down by the tiers that Cynthia mentioned. That's used that we get those bills via keyword query. So they're pretty good, but they're not perfect. And so certainly if you know about an important bill that isn't on the map, please contact us and we can add it, and we kind of keep tabs on it by tracking it through this map. Next slide, Brian.
So one of the issues, thanks, Sam. That's a good segue into kind of just, we do track just these issues. Right now we're tracking about 75 or so, maybe 78 bills at the state and federal level on that map. And so if you click on your state on the map, you'll see what issues in your state we're tracking. Now, not all state legislatures have convened yet, so your state might be blank right now, but we're anticipating legislation in most of the states. And in that legislative handbook that Sam mentioned, there's actually a calendar of all of the state legislatures and when they begin their session, when they convene and when they adjourn for the year. So you'll be able to take a look at that. One of the issues, this is sort of a perennial issue for us, is this licensure exemption for traveling team physicians, or a reciprocation of your license if you travel across state lines. I see Chad Carlson's on here. This was a kind of a hallmark from way back when he was chairing this committee, and we've been kind of chipping away at it state by state ever since. We're down to these last 4 states. We've been working already in Hawaii. The legislation has been introduced there, and it's making its way through the committees. I believe Kansas is set to introduce legislation when they go into session. So we're just, if you're from Nebraska, Oklahoma, reach out to me and let's figure out what we can do to just put this one to bed once and for all. We're also tracking several issues on concussion management, requirements on informing parents before the season about the dangers of concussion. Along that same line, there's several pieces of legislation on informing parents about sudden cardiac arrest and training coaches and school administrators and so forth to recognize the signs of sudden cardiac arrest. So just like Sam talked about, if you see a piece of legislation that's important, that you hear about in your state medical society or through your own professional contacts, that we need to be tracking on the state map, just reach out to me and we'll get it on the map, and we'll provide as many resources as we can to support you in those efforts. Let's move on to Dr. Schwartzen. If you want to take over on your slides, and we'll just carry forward.
Absolutely. Thank you, everyone, for coming. This is our update. Brian, next slide. So last year, I went over the changes that were effective as of January 1st, 2021, which were very significant. And to summarize them extremely briefly, everything switched from the bullet points of 97 to either by time or by medical decision making. It allowed for time to have the components of everything that is involved in the office visit and not strictly face-to-face time. And overall, the goal of these new codes, or not new codes, the new variations of them, was to allow for less documentation burden. Next slide. So every year, how Medicare decides to divide up the pie is really based on dollar per RVU. Some of you may be on a RVU contract or have nothing to do with RVUs, but the way Medicare decides how to do payment, most commercial payers follow. And there was a almost 7.9% decrease on average that was scheduled to go into effect. Congress and the Biden administration stepped in, and it basically went down only 0.28. So understand when we talk about why advocacy is important for all of us to be able to tell our legislatures and our constituents that what we do, it matters. That helps avoid a financial complication when they lower our payments by 10%, which for those of you who are in private practice could be a big deal. Those of you who are doing vaccines for COVID and for other things, I just wanted you to realize that there's a lot more codes involved in this, boosters, different shots. If you want to know how to do it, the AMA on its website has an access tool. I have a little snippet here where you see that button, access tool. You just click that, you say the patient, the scenario that you have, and it gives you the proper CPT code. Next slide. Telehealth. So very, very big for some of us. The good news is that CMS will retain all the telehealth at least the end of 2023. So we have about a couple years to continue building on the work that we're doing and to see how relevant this can be to our practice. And if it is, to continue trying to push it through advocacy. There used to be a geographic restriction. So I live in Florida, and if I had a patient that happened to be in Montana and I wanted to see them via Zoom, before it was not allowed, and right now we are allowed to do that. There is an audio only issue that was previously not allowed. There are some exceptions now for mental health. There is an allowance for an audio only. And then there's also a modifier 93 that got added in case someone said, listen, I'm just not doing the Zoom, or their rule and they don't have access to internet, or due to socioeconomic factors, they don't have the technology. There is a way for you to use a code to only do audio only. There are many exceptions, so you'll have to check your local coverage determination. If you want to go to the next slide. So since last year, what's new? Well, obviously they made this huge drastic change, and we're trying to figure out what all the terms mean. So some things that have come up when you talk about using data points for ordering a test, it's so important to understand that if you order 3 x-rays on someone and they're doing that x-ray in your office, and you are charging for the technical component of doing that x-ray, and you're charging for the interpretation of that x-ray, you cannot use that as data points as part of your medical decision-making. However, if it goes to an outside facility, or if you're ordering labs or bone density or anything else that is not done in-house, it does count as part of your medical decision-making. Again, they're just trying to eliminate double dipping. You can see some of the things in quotes here. And on the bottom, I put in a link for a lot of the others, as well as a much more lengthy explanation than the brief sentences I put here. Next slide. So now, does this bring us closer to being able to have a level 4 visit in sports medicine? I think it does. So the national average for primary care docs to have a level 4 visit is around 50%. So we may not be on the whole seeing multitude of issues like congestive heart failure and diabetes, but there are ways for us to code level 4 visits. And I wanted to go over the main ways. One is by time. And it's very important that in the statement, not only that you put by time, but for clarity of billing and specifically clarity for the patient, because many of them now have access to their records. They say that you didn't spend 45 minutes with them. I waited in the office for 50 minutes, but I saw you for 10. So then you put in the statement that you spent time reviewing their chart and you looked at their x-rays and you made phone calls and everything that you did to count for that time. And so just make sure to document properly what you did in that time so that everyone is on the same page. Next slide. So here's a table showing you the 3 different sections of medical decision making. So you have problems, the data used to analyze, and then the risk of the treatment or management. And you need 2 of these 3 categories to substantiate a level 4 or moderate visit. So hopefully you'll have access to these slides later. Plus, they're also available on the AMA website. Very, very easy for you to Google and come up with it. But basically, you can see on the left, it needs to be something significant. So an acute illness with systemic symptoms, an acute complicated injury. When you look at the data category, the most common ones would be that you looked at their MRI and talked to them about it, or that you thought this was a surgical case and you picked up the phone and talked to the surgeon and said, hey, I have this person, do you think it's appropriate? Or, you know, whether you're transferring to another service. And you could even, in a way, depending on how the athletic trainers are labeled in your state, if they're considered healthcare personnel, talking to the athletic trainer to continue the management program, whether it's physical therapy or return to play, is definitely discussion with an external qualified health person. And then, of course, the biggest one that's used in risk is medication management, and that's starting or stopping any medication. Next slide. Now, we have, in a way, kind of an all-star in our group. Dr. Mark Grunner is a physician in the Maryland area. And when we talk about how a bill becomes a law, this is how a CPT code comes to fruition. And he's been working with CMS and the AMA to come up with these brand new codes that just started January 1st, 2022. And so for the first time, we'll be able to get credit for remotely monitoring our patients. And specifically for us, the most applicable would be physical therapy. Now, there are applications like web-based or cell phone-based applications that will collect the appropriate data by yourself, or if you're in a larger healthcare group, the numbers can be much larger, and you can certainly make use of your time and be reimbursed for it. Next slide. Here are some resources that are available. There was several articles recently in Project Practice Management Guide that's put out by the Florida Academy, the American Academy of Family Physicians. There were several articles detailing how to code visits, how to go over everything with the new rules. It's actually a great resource, and it just came out. Perfect timing for me to use some of their information to share that with you guys. Next slide. And lastly, a very shameless plug, since I'm giving a talk as part of our sports medicine economics webinar series. I'm giving a talk specifically geared towards fellows and young physicians, or any physicians that feel that they don't really have any background in billing and coding. So this is more of a 101 course, but it'll be March 15th at 7:30 at night. And this will be another thing that should be recorded and available to you guys in off hours. So thank you very much for attending tonight, and I hope this was helpful.
Let's turn the time over to Dr. Rodriguez.
Hi, everyone. Luis Rodriguez here. Thank you all for attending, for taking the time to be here tonight and get our updates. And, thanks to everyone in the committee as well for your work and your leadership. It really shows, looking at all of your slides, I'm sure we all can tell that the work that's being done is great. So my update is brief. As you know, we've been working on the Choosing Wisely recommendations and providing a second list from our organization. We already have a list in place, and we've been working tirelessly to create a second list. So we finally gotten that second list approved by the AMSSM board, and it went through the first stage, which is the medical reviewers of the Choosing Wisely campaign take a look at it and then accept them for further consideration. We've received comments back from them, and now we're in the process of considering those comments and making those edits. We are hoping we can have them published before the annual meeting this year in Austin. Brian, can you please go to the next slide? This is a working group, and I can't thank them enough. They really deserve all the credit. It's really been great working with this group of people. Carrie Denai, Elliot Hubert, Fields, Ryan Baker, Sangili Chandran, and myself. I really want to thank them all and give them all the credit because they're the true authors of all of these recommendations. Next slide, please. And these are the recommendations that have been approved both by the board and preliminarily by the campaign. We have a recommendation regarding the use of the Ottawa ankle rules to mainly avoid excessive use of x-rays. We have a recommendation regarding physical activity assessment and recommendation or prescription. Use of diagnostic ultrasound for rotator cuff tears. Management of pediatric buccal fractures in terms of how we mobilize them, how we follow up, whether or not we repeat imaging. As you may remember, the main objective of the campaign is to promote conversations between clinicians, patients, to do what the campaign name says, to choose wisely in terms of what tests and treatments are truly needed, and all with the objective of also limiting expenditure. And of course, our newcomer is the recommendation regarding early subthreshold exercise for concussions, which is also well received by the campaign. And again, we're just in the process of reviewing their comments and potentially making some edits for final submission. You can go to the next slide, Brian. And then, as you may remember, we've also been working with the Centers for Medicare Service, MACRA, MIPS subcommittees. The current measure that is being developed in our subcommittee is the episode-based cost measure for low back pain, which is currently on the field testing stage, which will end on February 25th. This is something that I also wanted to bring to the attendance as a great opportunity for member involvement. It's a great opportunity to use your expertise to shape the future of medicine in terms of what are the metrics that CMS is going to use to measure our performance. And as you know, that is tied to reimbursement in the MIPS program. I have found, that this is a lot of fun, as I put there in my last tab. Yes, it can be time consuming, but I really haven't found it to be very intrusive. As we all think in the committee that it is very important for us to have a seat at the table where these conversations are taking place. And we all also think that if you have a particular area of expertise, for example, if you see a lot of back pain in your clinic, or if you treat a lot of patients with knee pain, as these opportunities arise to develop new quality measures, your expertise could be truly invaluable. So please look for more communications from us when the new committees are announced. They usually do that when it's time to review new quality measures for acceptance into the MIPS program. So please stay tuned. That's all I have. Thank you so much again for attending, and thank you, Cynthia and Jim and Brian, for all of your hard work and your leadership in the committee.
Thanks, Dr. Rodriguez. Let's turn it back to Dr. LaBella.
All right, so we actually do have one more subcommittee update, but we're going to give Alex a little more time, Alex Diamond, who's on another meeting right now and hoping to log on to this webinar a little after 8:30. So before we get to the community advocacy update, I thought I would just give the highlights of all the practice and policy related talks and sessions at the annual meeting coming up in April. So we've got a few different opportunities for folks to learn more about practice and policy. So we will have our committee meeting, and I'm not sure yet if it's going to be at 6:15 or 7:15, but it will be on Sunday, April 10th. So please join us there. We haven't met in person in so long. I feel like this is my history here with leading this committee has really all been on Zoom. So I'm really looking forward to meeting everyone in person. Please join us. We're hoping for more of a forum similar to what we're doing now, but much more getting your guys' input and open discussion about some of these topics. And then on Monday, there's going to be a fellowship development. It's really more faculty development, but does apply to both. I'll be giving a talk on how to bring advocacy into your practice. So small things that you can do and big things to make change happen at the national level. And then on Tuesday, there's quite a few sessions. So we have an ICL in the early morning, and Alex Diamond and Ami Hempel are going to be leading kind of a roundtable discussion after presenting their community advocacy projects. And we're highlighting these two presenters because they've been previous recipients of our annual advocacy award. So that'll be a great session to learn kind of the nuts and bolts of how they put their projects together and how they succeeded. And then we've got a session on legislation of trans athletics. That's part of a whole session on the trans athlete. And then as part of the youth sports and physical activity in the community session, we have a few more talks on very specific projects, community advocacy projects. So come to that session, learn more about what people are doing kind of in the communities with the support of this committee. Great. And I don't know, if Alex isn't on yet.
I don't see him on yet.
I don't see him on. Okay. So I can give
search and rescue, or can you do this?
Let's see. I'm just scrolling to. Yeah. So I can give his update. So one nice thing that has happened is that the Sexual Violence in Sport Task Force has become an official subcommittee, which means that it's a permanent a group as part of AMSSM. So task forces are in place for typically a short period of time till they accomplish their task, and then they're done. But as a subcommittee, this will be an ongoing effort on behalf of AMSSM. So Kristen Abbott is the chair of the subcommittee, and they're currently working on developing resources and a toolkit for organizations to use to promote reducing sexual and eliminating sexual violence in sport. They're working on expanding collaborations. They're working with Safe Sport. There's a victim advocacy group that they're also working with. USA Gymnastics is already using a lot of their messaging. So stay tuned. I think that once the toolkit gets developed and finalized, certainly all the members will be updated, but it's something that we're going to want members on the ground to be distributing and connecting community organizations and larger sport organizations with this resource. The youth sport advocacy team put together a similar type of approach with the toolkit. It's on our website, it's active. And then there were 2 engagement awards that were, or I'm sorry, 4 that were awarded. We put out a call for projects. And all these projects are aimed at distributing and evaluating the effects of the toolkit on community-based organizations, sport organizations. So, and this is part of what will be presented at the annual meeting. So the progress that some of these groups have made with their engagement awards. COVID-19, there continues to be a lot of work done in this area, working with various other entities like the Health and Human Services, the CDC, the White House. AMSSM worked alongside these groups with putting out messaging around vaccines. And then finally, I just want to remind everyone that we do have a community advocacy award that we give out every year at the annual meeting. And we encourage everyone to submit who's working on community advocacy. The deadline for submissions will be at the end of February, and our committee kind of goes through these, and the winner will be announced at the annual meeting in April. So we encourage you to submit. If you have questions about what kind of things or what kind of projects would be applicable, feel free to reach out to us. But that's a summary of the advocacy subcommittee. And I think that wraps us up for the presentation part. And it looks like we have a good amount of time for discussion and questions. So I'm going to open up the chat. And if Brian, you have any last words you want to kind of summarize on these slides before we jump into that, feel free.
Yeah, I can just set the stage a little bit. So we actually put out in the last issue of the Advocacy Corner, we wanted to hear from you a little bit. And these are just some topics that in our committee leadership meetings, we were thinking from our perspective as committee leadership, that it'd be great to hear about these things. But actually, we would open it up to whatever is pressing you. We, from time to time, we get questions, specific questions about billing codes, and we have Dr. Schwartzen on here. Sometimes we get questions more general about the Choosing Wisely campaign or just some of the initiatives we're working on. And we've got Dr. Rodriguez. I mean, we have the whole leadership here. So whatever questions you have, we're open to. But really, like Dr. LaBella talked about at the beginning, if you have specific ideas about legislation that you're working on in your state or specific practice concerns that you have with starting up a practice or something that's vexing your practice or something that we can help with, that's kind of what we want to dedicate this time to.
No one has anything?
And feel free to unmute yourself and just ask. We're not, rather than calling on or raising your hand.
I see the question in the
yeah.
chat from Dr. Carlson about just spending a little bit more time discussing those new remote monitoring CPT codes.
So I will tell you that they are so new that we're still trying to figure it out. Right now, it is currently only offered or covered by Medicare. I've not heard of any of the commercial payers covering this. Many companies that have these web apps, and there's a few of them out there, are starting to reconfigure their program to have the 15 metrics. But basically, you sign someone up, they start doing their therapy, and you're supposed to get this feedback on how they're doing. Very similar to how you might get a point of care from a physical therapy that you then sign the plan, and maybe you talk to the therapist or you see the patient back. In this case, you don't necessarily need to have that interaction because the technology does that for you, and you can monitor where you're going with it. Our expert is Mark, who I will likely have him join me for a few minutes in that upcoming sports medicine webinar series on billing and coding. And he would be a much better person to explain the intricacies and details of it. And so, Chad, I know that may not completely answer your question, but we will certainly get all those answers to you and everyone.
Mark has some. Mark sent around some attachments and links. Maybe we can include those when we send out the slides. We'll be sure to include the links that have specific references to those metrics and so forth, and we can include that in the materials. Is that okay, Dr. Schwartzen?
Yeah, I think this is very exciting for a couple of ways. One, we all have patients that have busy lives and have difficulty either finding time to get to physical therapy, or in their budget, some people, their copays can be $100 a session. So I think this does open up access. And then in the broader scheme, we'll be able to collect a lot of data, which hopefully we could use for research to see how our different treatment options are working for patients. So it's very exciting, but it's also, 25 days old. So we sometimes are a little hesitant to bring up things when we would like to see how they shake out a little bit. But I think it's appropriate to put in those attachments.
Let's see, there's another question in the chat for you, Dr. Swartzon. Do you or AMSSM have any guidance on how to set up radio extracorporeal shockwave therapy as far as billing goes, provider billing or PT?
So as far as I know, I don't know any payer that covers shockwave therapy. So this kind of falls under the cash business that you would need to set up, which if you have a private practice, there's a couple straightforward ways. You find out what other people in your community are charging, or another is how much your time and equipment is worth, and overhead, and add in a profit, and you have a reasonable number to charge patients. In a larger healthcare system, whether it's hospital-based or university-based, these cash procedures can be a little more complicated to introduce, but certainly there's a bit of a capital project getting the shockwave, and then figuring out who in your office is going to do it. Is it you? Is it an athletic trainer? Is it a physical therapist? And so there are some details, but as far as I know, no one is paying for it. And so really the billing is very straightforward since it's a cash model. If anyone has any other details to add on that, I'm happy for you guys to jump in.
One thing I wanted to mention is we periodically get questions through the Collaborate website or through email that are specific about different coding and billing topics that I believe, and Brian can speak to this and how to find them. There's a history of this or a log that we keep on the Collaborate website. So you may have a question that somebody already asked us, and then there's a nice detailed answer already. So you don't have to wait for somebody to reply. You can kind of scroll through really frequently asked questions. And especially there's been several recently because of all these changes, and Michael's addressed them really nicely in the Collaborate website.
If you're not on Collaborate, be sure to log in there, and then you have to go to our, it's set up as communities, right? So you go to the Practice and Policy Committee community, and just, I think you can just check that you want to join that. And as you do that, you sort of become a member of that community, and you'll get the emails, and you can sign up how frequently you want to get the emails. You can be inundated with them, or you can just get a little digest once a week to show you what's been going on. So take a look at that if you haven't already.
The other thing that's being, that we should probably announce is that our section of the AMSSM webpage is being updated and is kind of under construction right now. There were a lot of outdated links and topics on there that we took upon ourselves. Our committee took on the task of revamping that section of the AMSSM website and making it really up to date. And a lot of what's going to go on there are some of these webinars, for instance. And as Michael mentioned, there's a whole series on the economics of sports medicine and the practice of sports medicine that is really once a month talks on various topics related to the practice of sports medicine, not just billing and coding, but hunting for a job, interviewing for a job, getting things started, contracts, and so on and so forth. So there'll be a nice library of webinar topics on our website, on our new website, our new and improved website.
That should be ready to go live soon. With the annual meeting and so forth coming up, we've got a lot of priority as far as websites go. We're prioritizing getting the annual meeting going, but hopefully in the next 2 or 3 weeks, we should have that little section on our practice and policy section of the website ready to go.
Mm-hmm.
I noticed Dr. Diamond joined us. I don't know, Alex, if you want to say hi.
Yeah. Hey, everyone. Sorry joining in late, but I'm sure Cynthia did a much better job of presenting my slides than I ever could. So it's probably worked out better for everybody anyway. But if you have any specific advocacy questions, please feel free to reach out to me. And I think the other thing I'll just sort of throw out, just because the deadline is a little different this year than previous years, is that I encourage you to apply for the Community Advocacy Award. I think this is the fourth year now that we'll be having it. And the deadline for that is going to be February 28th. So a lot earlier than, a little earlier than previous years. So if you have a project, something you've been working on, please consider submitting that. It's a nice cash award and a plaque, but more importantly, it gives us a chance to amplify what you're doing, not only to honor you, what you're doing, but also let other members know what you're doing and potentially implement similar ideas in their communities to help them as well.
We'll have a link for that. Thanks, Dr. Diamond. We'll have a link on how to access that application for the Community Advocacy Award in the next Advocacy Corner, which will come out in a couple of weeks. So keep an eye out for that. And if you have questions, if you missed the Advocacy Corner, you can always reach out to Dr. Diamond or myself, and we'll make sure you get the link to the application.
And trainees, all trainees are eligible for that award. So if you have trainees and down to medical students, we've had medical students apply too. So it's really open to all levels. Other questions, or maybe even just things that are going on in your state or in your community, issues that are related to practice of sports medicine, or some of these athlete safety issues that we talked about earlier, that, you know, even if you don't have a question, maybe just to update the group, what's going on in your state. I feel like as the calendar goes, right, Brian, that things have sort of, most of the states have sort of finished, or I'm sorry, finished for last year, but haven't really gotten going yet.
Yeah, they're coming online little by little. So I don't have a good count, but maybe half the states or so I think have kind of started up.
Mm-hmm.
Again, the calendar is there in the legislative handbook. I don't know. I don't want to put anybody on the spot, but I've been working with Dr. Carlson a little bit, not too much in Iowa. There's a bill that is specific to, it's not specific to sports medicine physicians. It's kind of generally applies to private practice in general, but I don't know, Chad, if you want to give us the 30-second rundown on that little bill direct primary care that you and I have been talking about. I think that's such an interesting issue, and it really does get to anybody on the call that's in private practice. Maybe I put Chad on the spot. I didn't mean to.
He said his
All right, just
microphone
his
isn't
microphone.
working.
Yeah.
Okay. All right. Well,
So since there's a lull, one of the things that's going on in Florida is last year there was legislation that passed that was a parental bill of rights, which allows parents a lot of control over their child's health care, which in the sports world meant that if you did not have specific consent from a parent, you could not treat a minor. So if you were covering a game and there was someone that got injured and the parent wasn't in the stands, in theory, unless it was an absolute emergency, you could not examine, evaluate, and treat that athlete. And so that is certainly something that both locally with primary care and with ortho, we're working to try and fix, because certainly they did not intend to keep us from trying to help our athletes on the field, but that is the current state in Florida.
that bill actually is quite interesting. It does, that's the unintended consequence of, good intentions, right? The parental bill of rights, they want to make sure parents are really involved in that decision making. But the unintended consequences, just like Dr. Schwartzen talked about, which is why not just another reason why advocacy is so important. The way that bill played out in the House version of that Florida bill, we had a carve out for sports, specifically for sports medicine, specifically for the cases that Dr. Swartzon talked about, and that carve out passed the Florida House. And for whatever reason, politics is what it is, but it was taken out in the Senate version, which is the version that ended up passing both and then went to the governor for his signature. So now we've got to backtrack there a little bit and see if we can fix that, kind of stitch up that hole that's in there so that we can do our jobs, with
The
our
glitch bill.
the glitch bill. That's right.
Brian, can you hear me now?
Oh yeah, you're coming in loud and clear now.
I'm calling in. So, yeah, just very briefly, if you look around the United States, there's a lot of bills that have been passed for direct primary care. So these bills all do the same thing. They provide an exemption for primary care practices that want to charge a membership rate to patients for monthly services, and the law provides an exemption to them from being considered an insurance product, so that you're not regulated by the state insurance commission as a medical practice in a business arrangement like that. But most of these state laws limit the exemption to a primary care practice. There's only 2 states, Florida and Georgia are the only 2 states that really have a more liberal take on this. And so here in Iowa, we're trying to put a bill through. There was already a direct DPC bill that passed several years ago, but we're trying to broaden it so that, obviously in our case, if a sports medicine practitioner wants to enter into direct care arrangements with his patients or her patients, that they can do that and not be skirting current law. So we introduced a bill last year, and it passed through committee and then didn't make it through the House last year because the insurance industry was fighting it. But it passed through subcommittee again this morning, and it'll pass through committee tomorrow. And I'm told that the insurance industry is softer on it this year, so I anticipate that it'll probably go through. But that bill would allow, cardiologists or gastroenterologists or any subspecialist that wants to enter into arrangements like that with their patients to do so. So we see it as pro-market.
It's a great issue, and I think it gets to a lot of, like I said, physicians that want to kind of branch out in some different areas in their private practice. So thanks for your work on that. And it just goes to show sort of the advocacy and lawmaking in general. It's just about trying to find that kind of that consensus, right, with the insurers and the hospitals and everybody else that's got their interests. That's what advocacy is all about, is to try to find that consensus through a legislative process, and sometimes that takes time. So appreciate all your work on that, Dr. Carlson.
Thanks everybody on this call. This has been good.
Yeah, I echo that. Thank you, Chad, for your input. One thing, just we have a couple minutes, and I realized, Alex, that in my effort to present your slides, I skipped over one of the highlights from the COVID-19 work that's been going on AMSSM. So maybe, because just released was some updated pre-participation return to play related to COVID-19 that AMSSM worked on. So I didn't know if you wanted to speak to that, if you're still on.
Sure. Are you talking about the studying the cardiac evaluation?
Yes.
Document? Yeah, sure. Well, I was hoping that you guys were going to figure out COVID by the time I got on, so it wasn't an issue anymore, but I guess that's not true. There was a joint task force between the National Federation of High School and the AMSSM, led through AMSSM with Dr. Dresner and Dr. Asif, and looking at medical evaluation for high school athletes, status post-COVID. You probably saw a couple of weeks ago a similar document released for the college athlete. And so this document, again, addressed your adolescent or high school athlete. And it's a nice document. It provides sort of a 1 or 2 page sort of explanation as to why decisions were made, and then the last page is a nice sort of flow chart to follow along based on asymptomatic, mild, moderate, severe disease. It's planned on being published in Sports Health upcoming the next hopefully a few weeks or so. But many of you who are involved with your state associations may see that flow chart now, because that was released to the state associations last week, because they were clamoring for help on what to do. And I'm sure many in your community, your schools, your general pediatricians and general FACs, asking for help on what to do with these folks. So you'll see it's generally much less restrictive than the prior versions, mostly, again, which is good because it's sort of following the data, and that we haven't really seen cardiac events like we were fearful of. So it pretty much eliminates any medical evaluation for those with asymptomatic or mild disease. And then with moderate or above disease, encouraging medical evaluation with varying degrees of additional testing, but really shifting more towards using clinical decision-making similar to other febrile viral illnesses. And it looks like Andy just posted the link in the chat on that too.
Yeah, thanks, Andy. That's helpful. All right, so we're up against 9 o'clock. I just want to thank all the presenters, all the subcommittee leaders. You're a fabulous group to work with. I'm really fortunate to have such strong leadership in our committee. We've got a lot going on. I hope this generated some passion and interest for those of you listening in. We sort of scratched the surface here. There's a lot of stuff that we work on that we would love your help with, and please reach out to us with questions, with ideas, and I hope to see everyone at the annual meeting in person. So take care.
Thanks, Cynthia. Thanks, everybody.
Thanks.